Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we interviewed Dr. Tressler. It was an important week to be tuned in because we learned and defined about his background, expert insight on partial knee replacement surgery, because let's face it, the stretched indications are a sheer act of folly. So, here it is again. Part one of the interview. We launched it with a brief history of his professional career, personal professional philosophy as it relates to orthopedic surgery, some Tressler trivia, his first job ever on a farm because Dad said so. Turned out to be a great experience for him. And then we overviewed failed knee replacement, which led to our upcoming case. Hear a little bit of that first before we jump into part two. Let's do the patient history and presentation in a few minutes.
Okay. So she presented to me after she had already undergone a partial knee replacement for osteoarthritis, which was presumably only involving part of her knee. And I think this is where the biggest mistake is made, and where the indications for these partial knee replacements are being they're being stretched. I think also, unfortunately, marketing has become such a huge part of healthcare systems in general. You see people marketing minimally invasive this, outpatient painless that. Come in and have only a partial knee replacement and the recovery is quicker. Okay, so you see doctors that are advertising that they can save your ACL or do just a partial replacement and make your recovery that much better and your knee function more like a normal knee after it's done. And so they're stretching the indications for the use of some of these devices, and this has actually become quite a problem in my practice because and today was perfect example. I removed a partial knee replacement this morning and replaced it with a total knee replacement. And I believe the patient he suffered for over 5 years, and he's going to do great. Okay, but it's not that easy. It makes the surgery much more challenging, and the outcomes in general, the expectation can't be that it will be just like if it was done with a complete knee replacement the first go around. And this is what happened, unfortunately, for the lady that we're talking about. She underwent a partial knee replacement, and she had, I wouldn't even say moderate, but severe degenerative changes involving more than just one compartment of the knee. So the knee has 3 separate compartments. Partial knee replacements are designed to treat arthritis that's involving only a single compartment. So if you have one compartment of the knee that's terribly arthritic and the other 2 compartments of the knee that are pristine or in perfect condition, theoretically you can do a partial knee replacement and have success. The problem is that that's a rare situation, especially as we get older. If you have a 30-year-old guy who crashes his motorcycle and has a fracture that involves the medial side of the knee joint and the rest of it's fine, there might be the indication down the road to do a partial replacement, and with success. But unfortunately, as we get older, it's a rare situation that degenerative arthritis, or any other type of arthritis for that matter, affects only one compartment of the knee, and then you have surgeons that are sort of stretching the indications, maybe because of advertising that they can get you better faster, etc. And she had, unfortunately, a very poor result with a partial knee replacement that really only solved, and I think actually solved the pain coming from one compartment of her knee, which wasn't the worst of the compartments. So,
and on top of that, you had an additional situation you had to deal with.
Right. So she had terrible arthritis in her patella femoral compartment, which is the compartment of the knee that involves the kneecap and gives you your strength to go upstairs, get up from a low chair. They did a partial replacement to relieve the arthritic pain coming from her lateral compartment, but she had progression of the arthritis in her patellofemoral compartment because it was not addressed with the surgery, and she ended up falling because her knee gave out and fractured her femur. She had a spiral fracture that went from the distal third of her femur all the way almost to her hip, and now she had a bad situation that was made significantly worse because she had to undergo emergency surgery to have her femur fracture fixed, which entailed placing a rod from her hip all the way to her knee. And this is, her femur wasn't even close to healed when I met her. I think it was actually shortly after the surgery she decided, and maybe you had recommended it, but to come and do her follow-up care after her surgery on her femur fracture with us, and that's when I saw her. So,
yeah, Dr. Brunding said, he's told a patient of mine, he says, you ask Dr. Larry to actually just send us maybe an easy patient? I said, no way. No. You're gonna. I'm not giving you. I'll give you some lobs as well too. But this is one of those situations, folks. As you're listening to Dr. Tressler detail this out, we had a problem on top of a problem. And problem kind of really is a soft way to say it. We have a quality of life issue on a lathe that had quality of life, and in a sense, had the right correct surgery been done with the first total knee, with the first surgery, it would have been better outcomes. Okay, so as far as the specific examination, well, patient presentation, just give us a 30-second visual, what she looked like when you first met her. That was part one, which led into our upcoming case, and part two. There was much more to part one. However, if you missed the entire show and want to be more in the know, then log on to my website, drlarryradio.com, hit the subscribe button, follow the links, and listen to that show. It's been uploaded now, which you can listen to at your leisure as a podcast. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge to the game, because today we're getting into part two of the interview with Dr. Tressler. Hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
Put yourself into this situation. You've worked hard your whole life, now retired, wanting to stay active, but as it goes with knees, sometimes they wear out. And you're going to want the best surgical option as it relates to your knee. Not your neighbor's knee, not your coworker's knee, your knee. Well, what happens if that surgical indication and option that was used is not correct or stretched, and now that knee of yours is worse? You need to know why and who can fix it. After having been in practice now for over 20 years, I think I'm running on 24, I run into many cases where a patient is left in a lurch. And in our local latest case, that's exactly what happened. Part two of my interview with Dr. Tressler is coming up. And at the end of the show, you're going to hear from the actual patient. Her own words, what happened with the first surgery and the first surgeon, and how Dr. Tressler, as he's done so many times now and over his career, gave her quality of life back. Here's the upcoming outline. Patient history and presentation, check. What the specific examination and diagnostics tools utilized for the case from Dr. Tressler. He's also going to explain the root cause of her pain, what the mechanism was. He's going to describe some of the conversations he had with her prior to surgery, and then he's going to get us into the revision process. He's going to kind of give us a mindset in the OR for a moment, what he observed, the challenges and difficulties he encountered, how he handled them, and then, of course, the conclusion for the case. How was she immediately after surgery, now, and the prognosis for the future. Then Dr. Tressler will give a general advice on potential failed partial knee replacements and failed knees. We're diving into the clinical case now. Patient presentation. Just give us a 30-second visual, what she looked like when you first met her.
She was grateful to be here, and I think she was nervous to hear what I had to say. She was relatively fresh from recent intramedullary rotting of her femur, so she wasn't really ambulatory, and she still had terrible pain in her knee. So she was really in a bind, because now she's got to recover from her femur fracture, and even once she finally does recover from her femur fracture, her problem hasn't even been addressed, the original problem. So I think she was relieved to be here, and I told her that I could help her, but it was going to be a multi-stage process. But when I'm done with her, I'm quite certain that I can make it so you're going to go back to everything that you want to do recreationally and enjoy life again. You just got to bear with me, because we got to do this in a staged procedure or technique. We got to let the femur heal. The hardware then has to be removed in order to do the replacement that she had was severely mal-positioned and out of alignment. And so it really didn't have a chance of helping her at all anyway. And then you got to go through essentially revision knee replacement surgery after healing your femur fracture and having all the hardware removed. So it was a multi-step process.
As far as diagnostic goes, what were you using?
So, this didn't require any real fancy diagnostics. It was routine x-rays, and here it is,
Yeah, that's
it's
simple.
Plain as day.
As far as the rod, because it sounds like it was done in essentially two stages, right?
Correct.
Do you recall, in kind of general memory, what challenges you faced getting the rod out?
Yeah. So in her situation, fortunately, it wasn't very difficult because she's a slender lady. When we have lots of larger patients and you're digging deep to try to get hardware out from inside of a bone, it can be very challenging. Even just getting the proper position on an operating table to get the angles you need to get the rod out. But fortunately for me and for her, being slim made taking the rod out quite easy. But we couldn't take the rod out for a year, so now she has to suffer for another year waiting for the bone to heal. And if you remove the hardware prematurely, you run the risk of the fracture recurring. So you got to make darn sure the femur is completely healed, and then you can remove the rod. And then you have to have a little grace period to make sure you're not going to have a problem before you dive into the knee. So
same thing, standard x-rays, you can assess that?
Yes.
Okay. Moving into the, when you actually did the revision, give us a little insight into the OR. Many of us don't spend time in the OR, or definitely not doing these types of surgeries, but maybe a theater of the mind for a few minutes here. You've got her ready and prepped, and you're going to do, now she's waited more than 12 months to get this final stage of this thing done. What is it? What was it like? What did you see? What did you have to fix? Any obstacles you had to overcome, and then take us home?
Yeah, her knee had gotten considerably worse in that period of time, actually, from a swelling standpoint and just pain. The partial replacement, as I mentioned earlier, was really malaligned, and it caused her whole leg to be malaligned. She had a terrible valgus deformity. The implants were placed in a varus position, which is the opposite of valgus, and it just, her knee was non-functional. She had pain with any weight bearing and had lost a lot of motion in the knee. So we worked with some exercises to try to restore some of that with the hope of regaining all of it after the knee replacement. The biggest thing for me is to make sure heading into the surgery that we're prepared for everything that we're hoping we're not going to face but could face. So in other words, they've removed bone from her knee to put the other implants in. You have to go in and remove the implants, and the idea is to try to do that without removing any extra bone, because you really need to have enough bone stock in order to place your new implants. And if someone has had excessive bone resected with the original surgery, or even worse, multiple previous surgeries, then there's all kinds of difficulty in terms of placing standard type of knee replacement implants and balancing those ligaments, which I was talking about earlier. Then you have to start bringing in revision implants, and that augment lost bone, and you just have to be prepared, because if you get into the middle of a situation, you say, oh, this isn't going to work with a routine implant, break out the revision stuff and it's not there, now we got a problem. So you have to be prepared for the worst and hope for the best. And that's planning with the reps from the company, which is huge. And they're such an unbelievably great resource. They can keep you out of a lot of trouble that you may not even know you're getting into. Now, I've had 25 years of experience now, so that helps. Okay, so I call the rep and say, hey, I want to review this case with you because I'm concerned about this. And they have all kinds of software that we can lay over the x-rays on the computer, and they'll say, yeah, I understand your concern, but I don't think we're even going to come close to having to worry about that, but I'll make sure I have all that stuff there for you just in case. But let's plan to do this or that. So it takes preoperative planning, going in with confidence that your plan's going to work, and even if you come across something that's unexpected, you're prepared for it. That's the biggest thing.
I want to circle back around to the top for a second. 25 years experience, you use the term malposition. How, in this case, was it malpositioned? Was it gravity?
Well, I'll be honest with you. These partial knee replacements are very, very finicky. And if the leg has deformity because of wear and tear, and you're going to correct it, there's lots of different described radiographic lines and parameters that help guide you when you're doing a knee replacement. But when you're doing a partial knee replacement, it is really tricky because you're not resecting the bone away, and everything looks kind of funny when you resect part of a knee, but not both sides of it. I don't know how else really to say it other than that it gets more confusing, at least in the mind's eye. The problem is that...
So it could look from a surgical standpoint, orthopedic surgeon A that did this had sights on it. It's finicky, looked like it was aligned, closed everything up, walk out the door.
And then you take a post-op x-ray and go, ooh, that doesn't look real good, you know. Mm-hmm. And that's the way it was.
Okay.
The problem, in orthopedics, and I tell patients this all the time, it's a fairly forgiving, believe it or not, it's fairly forgiving. I mean, people are coming in disabled, like can't hardly walk, and even if you do a knee replacement and it's not absolutely perfect, but it relieves the pain and they can walk, well, maybe the x-ray doesn't look great, but it's working pretty well, you know. The problem with the partial replacements is they are not forgiving. If they aren't put in exactly right, they don't work well with the ligaments that are still present in the internal part of the knee, and there's problems. I honestly, I would say that for every 10 people I see that have had a partial knee replacement, one of them is happy with it. And I think that's indications being stretched, but also malpositioning of implants, and they don't tolerate malpositioning. The outcome doesn't tolerate malpositioning of a partial replacement. So we're redoing them all the time.
You know, and this is why I like going over cases. And there's so much information that can be pulled from a case that just gets kind of thrown out like seeds into soil and grows from there. Everybody listening right now is picking up different tidbits of information. The process, partial versus total, ligaments, how they function, and then all the while the possibility that there is a fix and a correction. And those are just kind of some general statements to kind of lead off with. But then there's the specific, the granular stuff that comes out when you itemize a case like this and go through it. And that's why I do this, and I'm glad you decided to come on the air, because I thought this was going to be very relevant and important, not just to say, hey, you fixed a case, good job, high five, we could do that in 30 seconds. It's the how, the why, and some of the insight from the clinical experience and expertise, and you did it perfectly. By the way, folks, this is all off the cuff. We have an outline for the show, but he's basically, Dr. Tressler, detailing out for us in a very organic way to help us understand. And I think now, as we're drawing this interview to a close, there is a happy ending. Why don't you describe, I know how the patient is. Why don't you tell us how she is now?
She's doing great. She's absolutely thrilled. She does not have any pain that limits her activity. As far as I know, she's back to doing everything that she wanted to be able to do. And, even post-operatively, her x-rays, I knew she was going to do well. You go into it with a little bit of nerves. I hope I can make this turn out the way I want it to. And in her case, fortunately, everything went great. So
yeah, happy ending.
Yeah.
One final question, and we're going to wrap this up. Just give the listeners some general advice regarding potential failed knee replacements and maybe what to do about it.
So the best advice, I'll give couple answers here, but most importantly, what you want to avoid is a failed knee replacement. The best way to avoid a failed knee replacement is to never have one. So
smack the forehead, right?
Do your due diligence. I tell patients all the time, they come in and hey, am I going to be able to get on an airplane 4 weeks after my surgery and travel to this or that? And I say, listen, this is a life-changing thing you're about ready to go through. You're going to have a surgery that is going to decide how the rest of your life is going to be, whether it's going to be an active lifestyle, painless, or are you going to have, persistent problems and suffer for the rest of your life with knee pain. So if it means that you get multiple opinions before making a decision, definitely do your homework, because you get one chance to make a first impression when you're having your knee replaced. Sometimes you get two, but most of the time, the best chance for success is the first surgery. So there are very few situations where a partial knee replacement is going to be successful. They're being used, and like I said earlier, I believe people are stretching the indications in their use. So if someone tells you that we're going to do this partial replacement, it's going to be great, that should set a light bulb off. Okay, you know what? I think I'm going to see what someone else has to say before I jump into that, because although it sounds great, it's not reality.
Yeah, great way to answer that. Dr. Tressler, if listeners want to contact you for an appointment, what is the phone number at OSMS?
The phone number is 920-430-8113.
Okay. And Dr. Leschke, it was new, and the only question he couldn't answer was the
phone number?
No, the website. The website.
I'm not sure I can answer it either.
Well, it's funny, too. People ask me my phone number at the office or fax. I actually have to pause to think about it because I never use it, right? So we'll give the website out at the end of the show, folks. Dr. Tressler, I really appreciate you coming on the show, spending your time. Like you heard, he was in surgery earlier today, and we're wrapping this up, and he's got to get to another patient here in about 3 minutes. We're totally on time, which is nice for everybody in the waiting room right now, too. You took an hour out of your schedule to educate those on WIKB listening audience about this case, which this case basically led into a full discussion about knee replacements, partial knees, and you heard his advice after 24 years experience, what he sees versus just answering a test correctly on a board versus real life. Dr. Tressler, thanks again for coming on the show.
Thanks, Dr. Larry. My pleasure.
Great interview, but we've got more. The patient's coming up. Was this knee issue all her fault? Was she to blame? Sounds silly for me to say that, but you want to hear why those words were swirling around in her head before seeing Dr. Tressler and getting the truth from him instead. Let's hear from the patient. Did you know right away that something just wasn't right?
Yes. I kept going to the doctor and asking him if something was wrong because it just didn't feel right. I only had a partial, but
right.
It just didn't feel right.
Mm-hmm.
And every time I went to him, he blamed me. He said I wasn't doing my exercises. He was going to cut some tendon in there to make it better and all this stuff. And I was like, no, you're not cutting anything anymore.
Yeah.
So I had kept thinking I was going to go down and see Dr. Tressler, and then I kind of put it off.
Right.
And then I fell and fractured my femur.
And that really delayed stuff.
And that delayed stuff big time.
And tell us about that for a second. Like, so you have this partial knee replacement. You know that something's not right. And by the way, folks, we're on with Joan Masato from Crystal Falls. She's the patient.
I'm the patient.
That we've been talking about.
Yes.
And all the while, you've been a patient of mine for a long time. I'm watching you walk prior to the slip and fall that you had. And I'm like, this doesn't look right. And we talked about Tressler, and then all of a sudden you had the accident.
Big fall, yes.
What happened with that one? You were walking on the walking path, and it was a nice day.
It was a beautiful day. It was January 1st, and I went for a walk. I was, at the time, really addicted to walking no matter what. It was slippery under the snow. I didn't see any tracks on the trail, and I was like, that's kind of wild. Nobody's walking today. Well, then I found out why. I slipped and fell, and my right knee went backward. I hyperextended it. Left knee went forward, and I straightened it out, and I knew right away something was wrong. I thought it was my knee.
Yeah.
So I called 911, and they took me over to Iron River. Had a great, the people in the ambulance were just great, and the sheriff's department was great. And they told me I had fractured my femur, and they were going to either send me to Ironwood, Wausau, Marquette, and I ended up in Marquette, and I had a great doctor there. Dr. Tressler said he did a great job on fixing the fracture.
So they put a big rod in. Well, let me go back.
Rod and pins, yes.
Rod and pins. When the accident, so it was on the walkway. There was an icy patch that you hit.
Yes.
Do you feel, because you have a pretty good recall of that, do you feel the knee hyperextended because it was unstable?
Very possibly.
Okay.
Very
So
possibly.
had the knee been structurally sound,
Right.
may have been,
It may have been.
yeah.
Yeah.
Because that was the first time actually that I recall that, and again, we had this conversation a while back, but that the knee actually buckled and then you hyperextended, you said.
Extended, yep.
So they do the surgery. You're in the long recovery of the femur. All the while, the knee's getting worse.
Right. So I'm in recovery, and I could either go back and see the doctor up in Marquette, or I could go to somebody else. So I decided to go to see Dr. Tressler, since I wanted to go see him about my knee anyway. It was a few weeks after the surgery, so I was still really in tough shape.
The femur surgery.
The femur surgery. So I wanted him to check it out, and they did some x-rays, and he came in the room, and I love that he's so truthful. He's like, your knee is a mess. He's like, whoever did the surgery on your knee should be ashamed of himself. And you're going to need a whole new knee replacement. But first, your femur has to heal. And we have to take the rod and pin out, and then we could do the surgery. So you need 2 surgeries. So I was like, oh, my goodness.
You're in the headlights.
Yeah.
But it was the truth.
It was the total truth. Yeah.
And it made
and once I digested it, I was like, okay, this is what we have to do.
Yeah. And that process then, and that's the thing too, like you said, and why I like to use Dr. Trust for complex cases like this and regular ones as well, as he will tell you like it is.
Yes.
Yes, and does it in a way that and it kind of almost looks like a watershed moment. Like you knew something was wrong with the knee. It wasn't your fault.
Right.
And so what was the timeline between the recovery from the femur and getting the knee replacement? How long was that? I guess everything involved. Is it?
So a year after, I needed a year for the femur to heal. Mm-hmm. Then I went to Dr. Tressler, and he said it was looking really good. So we scheduled the surgery for the rod and pin removal.
Okay.
And that was in, I believe, January also.
Okay.
And then I had to wait 6 months for that to heal before, and to make sure everything was okay before I went for the total knee replacement.
And you went through the surgery, got out of the surgery, and how does the knee feel now?
Oh, it feels so much better. It does make a little clicking noise, and
Yeah.
When you have arthritis, you're never going to feel 100%, but yeah, it's so much better. Yes, he's an amazing doctor.
What was the last follow-up you had with him? What did he say about it?
To come and see him in a year, and that was like 6 weeks after I had the surgery. He told me, "You're doing great." He's like, "You can continue with your physical therapy or not. It's up to you." He said, "Come see me in a year."
Perfect. And that's
Yeah.
what you want to hear from an orthopedic surgeon after you get done. That means
Yes.
things are going pretty good.
Exactly.
Joan, thank you for giving us your version of the story. We heard from Dr. Tressler, of course, folks, and Joan was kind enough to come on the air for a few minutes here and just give us her perspective, and I really appreciate it. And again, I saw you walk in here when we came into my studio, and you're walking pretty
Much
good.
better, yeah. And I must say, OSMS, I've seen several of the doctors there, and they are fantastic. They're so professional, and from the minute you go in there till when you come out, they are wonderful.
Glad to hear, and that's why I tend to use them as my primary source for orthopedic referrals. They just tend to do a great job, and people are here. 2 hours is no big deal down to Green Bay. Thanks, Joan, for coming on the air.
You're welcome.
So what a great ending to the story. And as promised, I'll give you their website, osmsgb.com. You can schedule appointments on there, and they've got some information, locations, etc. A little commentary, final commentary on this interview in case. As you know, beyond backs and spines, a lot of my day is spent on diagnosing and treating hips, knees, shoulders, ankles, wrists, elbows, you name it. If it's in the axial spine or extremities and it's a movable joint, I'm there. And over the years, I've heard your fears, comments, and concerns, especially when it comes to all types of surgery and specifically joint replacements. So for my patients and you listeners, I will bring you those specialists that have proven themselves and or can give solid advice. It is a vetting process, and occasionally I will and have to prune the bunch for various reasons. And as you heard in my monologue, OSMS is one of the best. They are doctor-owned, which is unique too, and patient-focused. However, not just words, they put it to action. So between the spine physicians, sports medicine doctors, the various orthopedic surgeons, and interior employees, it's quite the collaboration and combination of experts. I'm in sort of communication with them at OSMS on a weekly, if not a daily basis, for my patients and for you. For example, they can now do EMG studies. So if you have an order for an EMG from your doctor and need to get it done, they can do it now. Just referred the first patient down there from the area. They have an urgent care. I evaluated a recent case and deemed it necessary that the patient go to their urgent care. He was heading out of town on a flight to Appleton. I let the interior team know at OSMS, and they were ready for him. Countless cases, scopes, fractures, total joints, injections, second opinions, you name it. Dr. Radel just fixed a fractured kneecap from a local lady. She came to see me with a limp and a problem. I diagnosed it, sent it over to him. She's recovering. Dr. Flannery, he's about ready to do another total hip for a local lady coming up. She called my office. This is, who do I go see? And I gave her the name and phone number. Dr. Scheckinger, we collaborated on a knee for a local guy that he turned out didn't need surgery. Just did an eval on a slip fall case that happened in January. This guy hurt his shoulder. The patient went to the ER, saw an ortho from another hospital who did not explain much of anything. Patient came to see me. I evaluated his shoulder. He showed him the anatomy of the problem, described it, gave him some home care advice, and I'll follow up with him in a month to get ready for the golf season. And by the way, he looks at me and says, as I'm talking to him, I've got 2 Tressler knees. So we had a little fun chat about that. So in this case, I could give him eval. Most likely all will be okay, but if it doesn't, I'll send him down to Green Bay. Another lady right now who had right hip, groin, and leg pain. She had it for a year, came in, saw me. I did a history eval, ordered x-rays. She needs a new hip, severe OA, bone on bone. Pulled out the number for the guys. I said, you got to go. And she says, I can't, Dr. Larry, for various reasons. I can't get a new hip yet. I said, they're pretty good and fast on recovery, but, hips are generally pretty forgiving if you need it, but couldn't convince her to go just yet. So I decompressed the hip with the no cartilage in the joint. She's walking without a limp, no pain in her right leg, no pain in the buttocks and groin. She's doing pretty good, and I told her, it's a big Band-Aid I just gave you. Eventually, this is a one-way street. You're going to have to get that hip replaced, so she knows where to go. So again, these situations where you don't want to get stuck in, what happened to our local lady. So the combination of cooperation, collaboration, and consideration for your bone and joint care through a lot of effort between my office and from what OSMS does. Keep in mind, they do a bulk majority of their surgeries on site, which translates to some of the lowest infection rates in the country. That's OSMS in Green Bay, and they've got a location in Marinette. Some folks like to use that one as well.